Mhm. Let's see. I'm going to wait just another moment, and we'll start in just a minute. Still have people joining us. Mm-hmm. All right, I'd like to get us started at this point. A hearty welcome to all our council members and guests to this afternoon. Well, it's this afternoon here where I am, but whatever it is, it's in your part of the world. It's the Council on Linkages between Academia and Public Health Practice meeting this afternoon. I think as we start, of course, we want to remind everyone that we are thankful to CDC's National Center for State, Tribal, Local, and Territorial Public Health Infrastructure and Workforce for providing the funding support that's enabling the Council's current activities. And as we prepare to get started here, Maela, if you would perhaps go over housekeeping items.
Absolutely. Thank you so much, Bill. Just a couple of housekeeping items. Audio is available via computer or phone for this meeting. We ask that everyone please keep themselves on mute when you are not speaking. But as Ron mentioned, we do invite you to turn your camera on. We'd love to see your faces. Please also feel free to put comments in the chat box at any time during the meeting and to open your audio line to speak during discussions. This meeting is being recorded. We will use the recording for note-taking purposes, but it may also be shared publicly. Grace will also share today's slides in PDF form in the chat box, and all of today's meeting materials will be made available on our website. Please feel free to call on me or Grace. Grace is using the PHF webinars name, so look for that. At any time throughout today's meeting, if you have any questions about audio or technology. And with that, Bill, I will turn it back to you.
All right, thank you, Maela. And as we usually do, as we start a meeting, just a reminder, especially for those who may be new to us today. Here's the mission of the Council on Linkages. We are here to improve the performance of individuals and organizations within public health by fostering, coordinating, and monitoring collaboration, promoting public health education and training, and developing and advancing innovative strategies to build and strengthen the public health infrastructure. And of course, you'll be hearing a little bit more about this later when we talk about the Council's strategic directives. The Council is made up of, I think, you want to move the slide ahead, Grace? Yeah, there we go. The Council is made up of these 24 national organizations, plus, of course, the staff provided by the Public Health Foundation. And again, we're all come together to focus on workforce development initiatives that we hope will broadly benefit the public health, population health workforce. Here is today's agenda that you've all had a chance to review, I think. See that we do have some membership votes to do today. We'll have some updates about the Public Health Infrastructure Grant Program and the Public Health AmeriCorps. Then there will be updates about the Council's major activities at the moment, and then a review of the council's strategic directions. And then finally, we'll learn a little bit about the CSTE applied epidemiology competencies. So let me ask if anyone has anything they believe should be added to the agenda. Hearing none, then we'll move ahead with that agenda. And now I'd like to go on to approving the minutes. Grace, do we have a quorum for this? Do you know?
We do, yes.
Okay, excellent. Thank you. So you've all had a chance, I think, to review the minutes. So I would like to have a motion to adopt the minutes as distributed.
Chair, I move approval of the November 30th council minutes with accolades for their comprehensive and accurate transcription.
Oh, thank you very much, Dr. Gilmore. Do we have a second? Second from a council member.
This is Michael Fagan representing Sophie. I second.
All right, thank you so much, Michael. Now, are there any additions or corrections? Hearing none, then let's move ahead to vote on the motion on the floor. All those in favor of adopting the minutes as distributed, please say aye. I think that would.
Aye.
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 Good, thank you. Any opposed? Any abstentions? Very good. The minutes from our previous meeting are approved. Now, those of you who have been on calls with us before may be wondering about why Kathleen Amos isn't with us today. And I wanted to ask Ron to bring you all up to date on what's going on with Kathleen, who is currently on leave from the Public Health Foundation. Ron, if you would.
Thank you so much, Bill. So really good news. Kathleen is a new parent. Her daughter's name is Anna, and mother and child are doing quite well. Kathleen welcomes everybody. She misses being engaged in the council activities and all of the public health activities, but she's doing a lot of public health practice right now with her daughter.
Very good.
We anticipate Kathleen returning early part of September, and so we really will look forward to that. Bill, also, if I may, I just want to thank Grace and Maella for just stepping in and really running with all of this. You guys have been doing a great job and really, really appreciate it. And when Kathleen returns, she won't even know that anything was missing there. So thank you so much.
All right, thank you so much, Ron. So our first order of business, as you may remember, the Council on State and Territorial Epidemiologists, CSTE, has now completed its preliminary membership period and is now eligible for formal council membership. I think most of you will remember that organizations join the council first as preliminary members, and once that preliminary membership period is completed, usually a year or a little bit more, the council votes on whether to grant the organization formal membership. So I want to give the CSTE council representative, Erica Smith, an opportunity to say anything to the council that she would like to at this point.
Hi, everyone. Thank you so much. Can you hear me?
Yes.
Great. Thank you so much for having me. We're very happy to be here. CSTE is the home of applied epidemiologists who work in state, local, tribal, and territorial public health departments across the country. We have a rather large membership, and actually our annual conference is next week, so we are really looking forward to reconnecting with each other after a few years of COVID activities. We're very excited to be joining the Council on Linkages. Our mission is fourfold: to promote effective use of epi data to guide public health practice and improve health, to support effective public health surveillance and epi practice through training, capacity development, and peer consultation, to develop standards for practice, and advocate for resources and scientifically based policy. I am currently the steering committee chair for workforce within the organization of CSTE. And in my day job, I'm actually the deputy state epidemiologist for the state of Delaware. So very happy to be here. I don't know if you have any questions for us before we move forward.
Mhm. We'll see. Are there any questions? Any questions for Erica? Hearing none, then we'd like to proceed to vote. And the way we want to do this is to ask council representatives to please send a private chat message to Grace Davis with your vote, up or down, or you may email your vote to Grace at gdavis@phf.org. That's gdavis, GDAVIS @phf.org. So if you will please do that as we move ahead, a little later in the meeting, then we'll announce the results of the vote.
And Bill,
Yes?
for Grace, it would be PHF webinars. If people look for that in the chat, it'll say right under everyone, it'll say PHF webinars, and that's where people can send a private chat to Grace.
Oh, thank you, Ron. Okay, good. Let's move on to the second vote then. The Public Health Accreditation Board, or FAB, has also completed its preliminary membership period. It is now eligible for formal council membership. Organizations join the council as preliminary members, as I just mentioned, and so this FAB has also completed its preliminary membership with the council. So let me ask the FAB representative, Rex Archer, if you're with us, is there anything you'd like to say before we vote?
Well, this has been just an outstanding opportunity for us to work with all of you and to understand more what's going on, so that as we continue to improve and update our standards for governmental public health, whether that be local, state, tribal, territorial, Army bases, and even now a foreign nation. And I don't know, Marita, whether you have anything that you'd like to comment also. And then obviously would abstain from voting if we're allowed to vote before we're formal members.
No. Mhm.
Thanks, Rex. No, I echo that we really appreciate the partnership that we have with PHF and with everything that we gain from participating in the Council on Linkages. Thank you.
All right. Well, thank
And
you
Bill,
both.
And Bill, may I just add that both for CSTE and FAB, they both have been very active in our activities, core competencies in terms of using core competencies for CSTE competencies, FAB in terms of noting it in their standards, and also the academic health department partnership. So they really both have been quite engaged, which is nice to see as a council member.
Yes, absolutely. Let me ask, does anyone have any questions for either Rex or what is it, Marita? Hearing none, then please, if you would, council members, proceed and vote, as we mentioned before, either a private email to gdavis@phf.org or go to the PHF webinars in your chat box and send a private note to PHF webinars. All right. Thank you. As I say, we will, a little later in the meeting, we'll come back and Grace will let us know what the results of the voting have been. Ron, I think we can move on to you now at this point for a discussion about the public health workforce.
Great, thank you so much, Bill. You know, for more than a year, rebuilding the public health workforce has been a topic for the Council on Linkages meetings. The COVID-19 pandemic certainly has reinforced for all of us the tremendous need for training, recruiting, retaining public health workers. And Council on Linkages members in both academic and practice settings can really help out in this situation and support efforts in all three of these areas. This has really been the primary reason for us continuing to discuss rebuilding the public health workforce during Council on Linkages meetings. Today, we're very pleased to have with us John Carlson, who is CDC's program lead for the Public Health Infrastructure Capacity and Implementation Branch. John will share with us insights and updates about the Public Health Infrastructure Grant Program. We're also pleased to have with us Stephanie Dunson, and Stephanie is a public health advisor at CDC in the Division of Workforce Development. And Stephanie will share with us information on the Public Health AmeriCorps program. After both John and Stephanie have had an opportunity to present, we'll then open up the floor, if you will, for questions, comments, and hopefully a very vibrant discussion. So John, let me turn it over to you.
Thanks, Ron. Glad to be here today. And just a little bit about myself. I've been with the core team that has helped to stand up the program and also implement the program over the last 18 months. We've grown from a small little team of 3 to 30, and we awarded the grant at the end of last November, and we couldn't be more pleased with where we are today, 6 months in post-award, and looking forward to talking with you all a little bit more about the grant. Next slide. So I know it was kind of introduced of where we sit, the National Center for Tribal, Local, Territorial Public Health Infrastructure and Workforce, more affectionately known as the Public Health Infrastructure Center, but wanted to point out where we sit organizationally to just give you all some context. So our program sits in the Division of Jurisdictional Support, and it's one of our aims in the jurisdiction or in the division to really reduce recipient burden. And we're kind of thinking differently these days about how we achieve that. And a lot of it is through technology. And right now we have 5 primary programs: the Block Grant, the Health Equity Grant, the Infrastructure Grant, and Tribal COAGs. And we have a nice portfolio of about $7.5 million in funding. And using that technology, what we're really aiming for is we're using a system called that we call 5 internally, and it's a Salesforce platform that we're really using to support the TA of the infrastructure grant. But the hope is over the next year or so is to get all of our infrastructure grant and COAGs on that system. So really thinking of the power that we can achieve having that all in one system and being able to really be able to articulate what's going on across that portfolio to you all. Secondly, we're looking at a different organizational approach. Right now, we have each of the programs that I mentioned has their own project officers supporting each program. And so that means that the recipients have 5, 6, sometimes multiple project officers that they're dealing with on their specific grants and COAGs. Or we're looking at a regional based model where we may have one project officer kind of supporting all 5 of the grants and COAGs. So think about it, the state of New York would only have one CDC point of contact to deal with to really work through their entire portfolio. So we're excited about where we're going within the division and then especially within the grant. I put the little star there. I know Steve, Ron reached out to Steve originally to speak today, and Steve couldn't make it, but I know that you all know Steve well, probably from multiple and many interactions in the past, and this is public now, and just wanted to give him a little kudos that, and I can break the news for him if he hasn't told you personally, but Steve's going to be retiring from CDC at the end of August. So he's going out rather quickly. But again, I don't think that we as a program and everything that we've done in the center and the division could have done it without him. So we only have Steve for a short period of time kind of going forward. Next slide. So what do we define public health infrastructure as? It's the people, the services, and the systems needed to promote and protect health in every U.S. community. And we really kind of focus on kind of big bucket activities to achieve this. And if we could kind of name them, the first one would be flexibility. I think we're the first ones ever in a NOFO. We actually used the term maximum flexibility for our grant and really wanted to give the funding to the jurisdictions where it was needed most. We embrace the cross-cutting nature of our grant, to support the people, the systems, and the services which kind of we comprise. And then to that end, we recognize that we're disease agnostic. You know, if we support the public health system as a whole, it's a rising tide approach that's going to improve all disease outcomes. And then finally, we recognize and we promote health equity. The program was designed to meet our communities at their doorstep to improve public health across the country. Next slide. So this is our kind of broad overview about everything about the grant. Currently, we funded over $3.8 billion to our recipients. We expect to fund over $4.5 billion over the 5-year period of performance. And there's 107 recipients coming from all 50 states and 22 cities, large counties, territories, and freely associated states. Our strategies are our workforce, foundational capabilities, and data modernization. The important part of the workforce that I want to point out is all $3 billion in funding was put out at once in year one. So really our recipients have all 5 years of the period of performance to recognize that. For foundational capabilities, I think that this one is best aligned with your all core competencies, from the leadership and management and financial and systems and data. Really, these are the internal workings and the guts of the public health departments that they need to run themselves to support all that they have to accomplish. And we really think that foundational capabilities just aligns nicely with that. We're encouraged and excited for our second year of funding. This is increased from 140 million that we're going to put out $245 million in year 2 of the grant. So we're excited to see where this is going. And this is really the work that a lot of people have done on CDC's new infrastructure and capacity line that's supporting this strategy. And then finally, data modernization. We started out small for DMI. We originally only slated to put out $40 million at the door through our grant, but just recently we had an additional bolus of nearly $500 million that we're going to put out to support DMI. So we're really complementing internally at CDC the ELC program, which has predominantly worked in the DMI field as of late, but we're excited. And again, I think this speaks to the initial and early successes of our grant that CDCs and others are recognizing how flexible we are and how quickly we can get the money out to support things like DMI. So that's component A side, and I also want to recognize component B. We really took a novel approach with this grant where we have our 3 national partners, FAB, NMPHI, and ASTO are really the backbone of our technical assistance approach. So they provide the training, the evaluation, the communication, and the coordination that the recipients really need to help efficiently and effectively spend our money. So we've had a wonderful working relationship with the 3 of them. We're excited to go forward and working with them all. And I know a number of you for your other organizations are kind of supporting them as subs for this. And so what we have all tying it together, we kind of call it our 3-legged stool. We have our recipients, we have our national partners, and we have our CDC project officers. We kind of, that's our 3-legged stool. And again, I referenced 5, our TA system. We really use that system as the glue that holds us all together. And as we're working through this, we're excited to see where we can go with that. Next slide. And this is, again, I wanted to show you all the kind of high-level grant program outcomes. Really, this slide shows the outcomes that the jurisdictions are required to achieve by the end of the 5-year period of performance. And ultimately, the program will lead to accelerated prevention, preparedness, and response to emerging health threats and improved outcomes for the public health areas. Next slide. So when I first reached out to Ron, he asked me to give a few examples of the infrastructure grant and academic partnerships. And so again, I just want to give you a little context on how I did it. With our 21 project officers, I had to kind of manually reach out to them, and they're reviewing their work plans, and they know their recipients, and they gave me nice little narratives and write-ups and all of this. Well, again, you're going to get sick of me here saying the word 5. We're really excited about our systems approach to this. Think about once we get this all coded into our system for any of these, the partners calls we have, for our recipients, for the big data reporting purposes, we're going to have any and all of our work plan data coded to academic partnerships. We'll use the keyword, and hopefully we're going to use that systems approach. So rather than a couple hours worth of work to manually call this. We're looking forward to pushing a button and being able to keep you all updated regularly for this. So I have a whole number and host of examples of the academic partnership work that we're doing in FIG. I did 3 selective states that I'm just going to highlight for you all. But in the post-meeting materials, we'll have all the examples for you all to look through in your time. So next slide. So the Arkansas Department of Health is funding 30 scholarships to county health officers from the University of Arkansas Medical Sciences. And this is a big part of their initiative for what they're doing with their workforce funding here. Next slide. Next, we have the Kentucky Department of Public Health, where they're going to increase internships and specifically focus on funding Kentucky's HBCUs. And then finally, given the example of the Virginia Department of Public Health is going to send their staff to the public health professional development at VCU, upskilling their workforce. And so again, these are just some high-level examples. I don't have I'm looking forward, as probably you all are, to seeing the outcomes of all this. This is just, given the fact that we're 6 months in, this is kind of what the recipients have committed into their work plan. And I have a whole host of other examples for you to look through, but hopefully you can have me back in a little over a year or so, and we can actually talk about what the impact that this has all had. So I'll end there. I welcome at our discussion your thoughts and any opportunities and future connections that we can have with all of you in the council. And with that, I'll turn it to Stephanie. Thank you all.
Thanks, John. Good afternoon, everyone. As mentioned in the introduction, my name is Stephanie Dunson, and I am on that. My picture per se is not on that big org chart, but the one that John shared, I'm in the Division of Workforce Development. So just in context of we're all in the same new national center, I think, who's that? Bill gave the new name earlier, so please don't ask us to repeat it. So the new Infrastructure Center, Division of Workforce Development. Next slide, please. So as you all know, Molly Killam used to be the technical monitor for the Public Health AmeriCorps project. And so Molly left us, oh my goodness, about 3 months ago, and I got the opportunity to work on this project. I am on the Division of Workforce Development Policy team. However, I was granted the pleasure of working with the Public Health AmeriCorps project. So I'm sure you all are already familiar with the project, so I'll just kind of give you some 2023 updates on where we are right now. So as you know, this was a historic initiative made possible through the partnership of CDC and AmeriCorps. We are now in the 2nd year of the program. And as you know, the program is supporting grantees and members to have a pathway to public health. So our purpose is to just increase the awareness about public health and getting people coming out of high school to go into public health and have an awareness about public health and also AmeriCorps in general. So in April, Public Health AmeriCorps announced the award of more than $90 million to 100 state and local organizations for a 2-year period. This award includes the continuation of 78 existing grantees and 27 new awards. This will help to support more than 4,000 members going forward. So with the intent of bringing on at least 4,000 more Public Health AmeriCorps members. In addition, Public Health AmeriCorps has partnered with the AmeriCorps Seniors Project to announce the award of more than $800,000 through the Older Americans Workforce Development Program. So there's a few highlights here on the screen you can take a look at, and then also just note the website there if you want additional information about some of these numbers that I just mentioned. Next slide, please. Thank you. So eligible organizations to apply to the Public Health AmeriCorps program include local public health departments, state, local, and territorial government entities, nonprofit organizations, faith-based, tribal, and community-based organizations, as well as higher education institutions. Members who are interested in applying to Public Health AmeriCorps can apply for either a part-time or full-time position using the AmeriCorps local-based search tool. So depending on the positions that are available in your local area, members can select the type of opportunities that they're interested in. So benefits, in case you know, young person who's interested in this, include hands-on training, a living allowance, education award, and student loan deferment or forbearance if applicable. Members will work on a variety of activities, including health education, community outreach, linkages to care, and research. CDC is also partnering with a few organizations such as APHA, ASTO, NACHO, CDC Foundation, and NMPHI under the 1802 Cooperative Agreement to support the Public Health AmeriCorps program. So each of these partners bring their own respective knowledge. They will also work collaboratively to increase awareness about the program and encourage state, tribal, and territorial organizations to become grantees. Next slide, please. So to support the workforce development and member engagement, Public Health AmeriCorps is building a comprehensive training and development program. All members are required to complete the CDC developed foundational training for Public Health AmeriCorps. This is a 16-hour self-paced program that provides public health foundation for those who want to work in public health. The course covers substantial areas such as public health science, health equity, and environmental justice. Skill-based information such as your soft skills like communication, writing, oral communication skills, policy development, and community partnerships. Public Health AmeriCorps is also working to build out opportunities for member engagement around networking and a project called Life After Public Health AmeriCorps, which includes opportunities that members may not have thought about going into public health after they finish the Public Health AmeriCorps project. And one relationship that we're exploring is with the CDC PHAP program. So going into PHAP program may be an option for Public Health AmeriCorps members once they complete the program. Next slide. So I just wanted to give you a few highlights from the National Public Health Week, a few shout outs that Public Health AmeriCorps received. They were featured in the Association of Schools and Professions of Public Health, ASPPH, during their National Public Health Week webinar series, and the NNPHI highlighted Public Health AmeriCorps during their Public Health Week launch of their Learning Navigator. Public Health AmeriCorps was also featured on the in the president's highlights for National Public Health Week, in which the president noted that at home, we have invested over $7 billion into strengthening the capacity of state and local public health departments to respond to future public health crises, including the launch of Public Health AmeriCorps to train a strong, diverse public health workforce for the future. Next slide, please. So you may wonder, what are people doing in the local communities? What are some of the experiences that they're having? So for example, one of the members in Michigan shared her experience in serving as a Spanish interpreter at a health center with Cherry Health. Has inspired her to get her master's in public health. She said, I'm planning to go back to school and get my master's in public health with a focus on community work, and my current AmeriCorps role is helping to prepare me for that. In LA County, we have a Public Health AmeriCorps member, Fareed Howard, who discussed his role in community outreach and health education on Skid Row. And if you're interested in seeing Fareed's commentary, it's available on YouTube, and I can put his name in the chat. It's Fareed Howard, F-A-R-I-D Howard. And so you just search on YouTube to find his commentary on his experience in the program. Also in New York City, we have members serving with the New York City Housing Authority. They shared their motivation to join Public Health AmeriCorps, and they highlighted the impacts that they're having in the community. One person shared, I'm hoping to use this as a foot in the door. I would like to be a public health advocate. If I had the perfect choice, I would work in sexually transmitted infections department in contact tracing, counseling, and prevention. And I'm also interested in maternity health. And additionally, we had a member who shared their experience working in Pima County, Arizona. that they have the opportunity to work in public health policy. So as you can see, our members are gaining a wealth of knowledge and experiences into public health and preparing them for future careers in public health. I did briefly see a note come up about PHAP. Although I am not the POC for that program, you can search for that on the CDC website. I do know it's a 2-year fellowship program for, I think, students who have completed their bachelor's degree. But again, you may just want to check out our website, PHAP. And if you have any questions, I think they have opportunities for you to ask those on their site. Next slide, please. Thank you again for allowing me just to share a few updates that on the work of CDC and Public Health AmeriCorps. It really is a great opportunity to teach more people about coming into public health and all the great work that we do. Thank you for your time.
Well, thank you so much, Stephanie, and thank you, John. I have about 1 million questions in mind, so I'm not going to go ahead with those. And let me turn it over to the rest of you. Questions, comments, observations for John and Stephanie both. So please, probably the easiest might be if you raise your hand, and then we could be sure to ask you to unmute. You could also use the chat box as well for asking your questions. So I'm sure someone out there has a question.
April, I think I saw your hand go first. If you want to come off mute and jump in.
Sure. Hi, everyone. I'm April Klein. I am a senior public health analyst at the National Network of Public Health Institute, so one of the national partners for the FIG grant. My question is, I feel, for the public health workforce to really be transformed in a, truly transformative, I think our strategies should really include recruiting people with maybe non-traditional public health skills and abilities and expertise, things like communications and marketing and strategic planning, project management, data visualization, those kind of things. It seems like there's a lot of missed opportunity to build out this type of staff in public health departments and programs and really market to people that have these type of skills, but, may not see the field of public health as a career path. Not to mention recruiting people that have lived experience with health disparities, but maybe not necessarily these core public health skills. So I just wanted to share that and see what thoughts or ideas that our presenters have about that.
Thank you, April, for that. I can certainly take that back to our Public Health AmeriCorps team and see how they can look at, expanding the eligibility and what that might look like for future applicants of the program. But I'll definitely take note and take it back to them. Thank you.
John, any thoughts from your side?
Yeah, and I completely agree with you, April. I challenge our project officers to say no and maximum flexibility and innovation. That's what we're all about. But again, it's hopefully, every recipient of ours is individualized on an individual basis, but hopefully we can, if and when they want to go that road or that path, we'll be able to hopefully provide the technical assistance ideas, kind of way to formulate and do that recruitment strategy to tap into that definite massive pool that of workers that really supports our core competencies that we need.
And if I may add to Stephanie and John, the Public Health Foundation, we're working with ASTO, NMPHI, and FAB as well as a partner with them in this effort. And part of what they've reached out to us on is around academic health department partnerships. And in particular, we've had discussions with ASTO about engaging HBCUs and other institutions to try to diversify the workforce, both in terms of race, ethnicity, as well as discipline. So it's something that is on the radar, and I suspect as time progresses, we'll see some pretty innovative actions out there. So Gary, shall we? I think your hand was up next.
Thank you so much. Can you hear me? Excellent. Thanks so much. John, my question goes to you, and it's a preliminary response in fairness and inequity with the question. I'd like to know if we can get a sense of rural settings that are being impacted, at least with the current knowledge that we have of the distribution of the funding, particularly because so often these settings are perhaps last in line, but actually more and more need to be right in the milieu of an event like this. Can you speak a little bit to rural settings and how that panoply of 107 health departments are trying to outreach to them?
Yeah, and I think that the two kind of pillars that we use to address the rural setting, and this is applicable to a number of other areas across the spectrum. But first of all, through our funding formula, we complemented that not only on a population-based approach, but we also used a community resiliency score. So that didn't necessarily, it wasn't directed specifically to rural settings, but I think it's reflected, and they got kind of additional dollars and additional funding due to these community resiliency scores that we use. And the second, although it's probably not the answer you're looking for, but we did have in our NOFA language that obviously, that most of the money is directed to the states. And so that same population-based formula, we included in there that they should be giving 40% of all funding to the local recipients. And again, I don't have a direct specific response to you on the rural piece, but I think those are really the two kind of focal areas that we use to address the different type communities there.
Thank you.
Great. Paul.
Thanks, Ron. And I just, again, this is so exciting to see us move in the direction of doing infrastructure building and having been at CDC at a time when we actually just sort of introduced infrastructure as a legitimate and important part of the public health system. I can say this is really so way overdue, but really very welcome. I guess a couple of points that I wanted to make. First of all, I'm Paul Halverson. I'm the founding dean at School of Public Health in Indiana and representing the Association of Schools and Programs in Public Health. I chair the Public Health Practice Committee. And a couple of points. One is related to the academic health departments to sort of suggest that I think that maybe this is an opportunity to, again, do some system building. And that's going to be a theme that I want to try to push on a little bit more, which is that we need to build stronger, more durable, sustainable linkages between our health departments at both a state and local level with our academic partners. And it seems to me that we have a very strong opportunity to work more collaboratively and to create more robust systems that would really focus on academic health departments. And again, I think that Ron and his staff have done an excellent job in sustaining our academic health departments in times of no money, but with a strong commitment to the importance of the work. So I would ask our CDC colleagues to think about that and perhaps comment. But then also, let me just say that I think from a system building perspective, as a former officer, I understand and appreciate the need for flexibility. But at the same time, I think we all have a responsibility to be thinking about ways in which to build strong national public health capacity, and solely allowing sort of a focus on letting 1,000 flowers bloom without standards seems to me to sort of lack the requisite opportunity to build strong, dependable systems. And in particular, I think about the fact that we do have now national standards for public health agencies with the Public Health Accreditation Board. We do have, I think, an important opportunity, if not perhaps an obligation, to be thinking about ways in which we can build a public health system that shouldn't depend upon where you live in this country, but actually the development of these national standards creates for us the opportunity to move in the direction of expanding accreditation. And again, I understand the importance of flexibility, but what could we do to strengthen the likelihood that we actually have standards that we're moving towards, at the same time maintaining the flexibility? And last, I would just say, as it relates to the workforce, I know we have a lot of people and a lot of different ways in which people come to public health, but again, we have national standards, a National Board of Public Health Examiners. There is the opportunity for people who don't have a degree in public health to get certified and to be part of a public health workforce that we can depend upon in terms of a system of requisite capacities that are based upon real world work in public health. And again, I think it's great to get the money out the door as quickly as possible to provide flexibility, but shouldn't we actually, as leaders, also be thinking about ways in which to build a strong capacity so that at the end of the day, when the investments have been made, that we have something that's sustainable and that allows us to have greater reliable public health systems. So I'll stop at that point, but appreciate any comments that you would all have.
John or Stephanie, any thoughts?
Yeah, I'll speak to your first, Paul, and it's good to hear the state of Indiana is practicing what you preach. I have a slide on Indiana that isn't on there, but actually we had a great speaker from the state public health department at our reverse site meeting in Chicago a month ago. In Indiana, they are the state public health department is working to stand up a program funded by our FIG dollars to do just exactly as you stated. So but we'd like to replicate that across. And your point number 2 about the standards. So I talked about the foundational capabilities that we're funding. And you better believe every single recipient that we're talking to, we are discussing accreditation and or accreditation readiness. And so that's on our number 1 agenda for every single call that our project officers are having and the regular conversations with them. And then we as program leadership that go out and have our specific site visits, we're seeing where they're standing in that process, and we're making sure we're kind of letting it be known where we'd like to see them to go. Ultimately, it's going to be up to them, but from our program's perspective, we believe in everything that you're saying.
And if I may add, Paul, in some ways, maybe outside of the public health infrastructure grant program, we've started to see more institutionalization of the academic health department efforts. So the Tennessee Department of Health, they have appointed an academic health department coordinator. Massachusetts has done something similar. And so that hopefully will begin to institutionalize some of these and build that more systemic approach that we're talking about. Carmen or Stephanie, I'm sorry, Stephanie, did you have any? Oh, I see you shaking your head. Shall we turn it to Carmen? Oh, Stephanie, you're on mute.
I'm going to say everything that Paul said. I wish we had notes on it, because that's something, from a systemic perspective that we would have to, sit down and have many conversations about. Doing things in government is not easy, nor does it get done overnight. So I would welcome those comments. I can put my email in the chat for you if you want to just maybe summarize some of the things that you said to share with us. Thank you.
Great. Carmen.
Thank you. Thank you so much. As Paul was mentioning infrastructure and building the infrastructure, and particularly around standards and standards of practice, it made me think a lot. During the day, I work at Department of Public Health, local public health agency. And at night, I'm a DRPH student and so it's interesting because I'm at two worlds where we're doing FAB accreditation. I'm part of the department that does the program workforce development plan. And so we're tying everything to the Council on Linkages. But at the same time, I am volunteering for accreditation of my school. And so for the Council on Education of Public Health, the CEPH. So I'm wondering now, are these things aligning? Is anybody working to align CEPH with FAB, with, you know, your education? Basically what I'm asking is, has anybody looked at whether CP accreditation in schools core competencies and tried to align them with the Council on Linkages and private practice of public health, you know, public health practice? Is anybody constructing any kind of infrastructure around the tying of schools and work? No? Yes? Maybe so?
I'm going to take that one real quickly as well. You know, the National Board of Public Health Examiners, FAB, ASPPH, CEF are all members of the Council on Linkages. And so we do have those discussions. And I know that CEF, as part of the standards they were working on and developing the competencies, they did use core competencies as part of that. FAB has also done that as well. National Board of Public Health Examiners has also taken the competencies into consideration. None of them say, take it absolutely, you know, here it is, plop, we'll use it exactly the way it is, but they all have integrated those to some degrees into what they are doing. I don't know if anybody else wants to address that as well from the organization's perspective.
Ron, could I just comment? I think you're right. I think there's been coordination, but I think Carmen is also correct. There could be much greater coordination and much greater alignment. And I think actually this is a sort of call to action for all of us as we do system building. So we could all defend how well we've done that coordination, but I think we could all agree it could be done to a substantially greater degree.
Absolutely, Paul.
Yeah, just jumping in from FAB, I agree that we worked a lot in our version 2022 revision process to have that alignment and that coordination. And FAB is a learning organization and we strongly believe in CQI. And so I agree that we can continue to build on those relationships. And as we look forward to our next revision in 2027, start working now to see how we can strengthen that alignment.
Somebody wrote in the chat that was a good dissertation. A dissertation work. Somebody's egging me on. Thank you. Thank you so much for that.
Sounds perfect. So Terry, let me ask you to chime in. You've been waiting patiently. Thank you.
No, thanks. Terry Brandenburg representing NACCHO. And, from a local public health perspective, this is just an incredibly welcome investment in our health departments. Sorely needed. We're going to be able to hire, key staff. We're going to be able to do the training necessary to meet whatever standards, FAB, whatever standards we have. But, as we roll out that investment in training of our workforce, existing training, and we align with the foundational public health services, a lot of that is more the technical aspects of public health practice. I call the science of public health. But I would hope that we don't diminish or put aside what I would consider to be the art of public health, and that would be around public health leadership. CDC for almost 20 years, starting maybe in 1990, made I'll call it a huge investment in public health leadership, both with a national institute and funding regional institutes. So as we roll this out and we use this very large grant, that we assure that we build in leadership training within our existing public health workforce. So I don't know if it's on the board or what the plans are, but make sure that we address the art of public health.
John, Stephanie, any comments?
Yeah, point taken. And as we work with our partners on ideas for proactive TA is what we're calling it. I think that kind of falls within our leadership bucket, but happy to reiterate that back to the group.
And definitely something that we can look to incorporate into our fellowship programs as well, as we're training students coming in from different fields of study into our fellowships at CDC.
And a comment about Public Health AmeriCorps and alignment. So the Public Health AmeriCorps, in working with CDC to develop the Intro to Public Health Practice Training Plan, that is built around 6 of the 8 core competency domains. So Public Health AmeriCorps, CDC all said, let's be aligned with the competencies right from the get-go, which is also, I think, going to help as we educate the new workforce for public health. Karen.
Thank you. I'm new to this particular group, but certainly not new to public health education. And now I'm a FIG evaluator for one of the grants in Illinois. So, I'm a dyed-in-the-wool curriculum developer educator, and I've participated in various points of the pipeline of education, from undergraduate to graduate education, and continuing education, and involvement to some degree with the two-year institutions. So, we have the training. We have a huge pool of potential public health contributors, but I can tell you from the ASPPH workforce studies, especially tracking undergraduates, we're the newest component really of, and maybe the biggest now component of the public health workforce, they don't go to governmental public health. A very small proportion of them go to governmental public health. So they are ready and willing, and they have skills, and they have training, and they have some experience. So I think we really need to look at how to segue them, how to include them in some of these agencies more easily, because it's very prohibitive to get them involved in any way. A little easier with the graduate students, and particularly in academic public health departments. And I want to say one other thing. I want to add my voice to this business of standards and accreditation and whatever. So in my first weeks as an evaluator, I walked in and said, has anybody mapped the FAB standards or requirements to the CEF standards, to the Council on Linkages skills and levels of practice? And I think such a document would be extraordinarily helpful to people who are developing curriculum, which I don't believe should be formulaic. Each institution and each group of professors has a different perspective that they bring to public health. And I think that that's really helpful. But it's very good to have a visual of how all of these things mesh without having to go to do it yourself, because I've done such kinds of things. And this mapping is a very labor-intensive process. So it would be really interesting if this group could take the lead and include perhaps CEF and FAB and maybe even ASPPH in some kind of mapping across standards project.
And I see a comment from Emily Burke that ASPPH Workforce Center is working on something like this. And similarly, we, Public Health Foundation, through the Council on Linkages, we're working on a visual of essential public health services, foundational public health services, and core competencies. How do these fit together? So, because none of us desire to confuse the field, but that often happens if we don't explain.
Yeah. Thank you.
So thank you for the comment, Karen. And Gary, you may be the final person to ask a question here.
Thank you, Ron. I should mention I'm with the Association of Accredited Public Health Programs, AAPHP. And it's important, this question goes to Stephanie. It's twofold, Stephanie, and I think relatively short answers can probably fulfill the responses. First of all, when you talked about the CDC course, which I was so pleased that you mentioned, the foundational training for Public Health AmeriCorps, I wanted to double check to see if you mentioned that is required. That's my first question. And secondly, would you just say a little bit more about life after AmeriCorps?
Thank you, Gary, for giving me easy questions. So yes, sir, the course is required for all Public Health AmeriCorps members. And the Life After AmeriCorps curriculum is to just prepare them. So Public Health AmeriCorps is working on building this out. So what does that look like for members once they complete Public Health AmeriCorps? What career opportunities are available to them? I saw my colleague JT Theophilus, he put his contact information in the chat. He's a representative from the PHAP program, the Public Health Associates program. But what other opportunities are out there for members to explore? You all have talked about other areas where it may not be traditional public health trained, but those skills are needed in the public health realm. So they're still working on building that out, and I'm sure there'll be more to come on that.
So Paul, even though we had Gary as the last question, we'll have a last. Oh, Gary, you were on mute. Was there a follow-up there? I'm sorry.
There wasn't. It was a thank you.
Great. So Paul, maybe you could be the last.
All right, thanks. I'll try to go quick. So the issue that I would bring up is, as a former state health officer and also as a current dean, I will tell you one of the systematic problems that we are yet to embrace, and I would love our CDC colleagues to comment on this, even though I know it's not under their complete control. Part of the real primary problem that we have in public health, particularly governmental public health, is the salaries and the antiquated civil service system that we find ourselves with at both the county and the state level. And frankly, all the money in the world is not going to fix this problem until and unless we can actually begin to influence some really, really broken civil service rules. And I understand not every system is broken, but if we don't look at this, it is going to continue to plague us. And I would just also like to say, for the record, 18% of our graduates going into governmental public health from state and local schools and programs in public health, I hope is our basement number, because we really need to do a lot better. If we're the schools and programs in public health, we need to be able to create incentives so that our students want to go to governmental public health. But there is still a huge problem, and I don't think anyone's really talking about this issue. And beyond that, more than talking, we need to do something to make it more governmental public health a more attractive, reasonable option for graduates. It's really crazy what we see across the country in terms of salaries and career opportunities for people with degrees.
And I'll try to respond as best I can, Paul, from our perspective. And that's really what we're looking at our workforce, $3 billion in workforce funding for, given all things are local. So we've seen everything from student loan forgiveness to one-time bonuses to across the board raises for everyone to sabbaticals as kind of workforce retention. I know we're going to have to get more creative to getting the young and upcoming graduating public health students kind of coming out. But again, if we can use those areas to entice things or get the mid-level career person, we've seen like the Shelby County in Memphis, they are taking their LPNs and using our money to get them RN degrees or use that kind of across the board in different ways, but back to maximum flexibility for it. So we can look to you all for creative ideas that we can get out there as ways to do as you just described. And again, let's, we're any and all ideas, we're taking them. But again, I think the whole point is to do this in a systematic way. We're all kind of thinking in moving along together. So if we can get that full quiver of different options, I think we can complement it with our workforce dollars to do what's the suite of opportunities to get that done.
So Bill, will you indulge me for a couple of 2 or 3 more minutes here and allow Erica to
Sure.
ask a question or make her comment? And
Sure,
I
absolutely.
can close the session out.
Mhm.
Erica.
Great, thank you so much. Yeah, I completely agree with all the points that were raised. The only thing that I will add is that not only is the system, I don't know what else to say, broken in terms of governmental public health, but it's also very complicated. Each individual agency, be it at the state or local or both level, has its own set of rules in terms of hiring, retention, salary increases or lack thereof, what types of requirements there are for different job categories across the swath of different types of public health. So I think it will be very difficult, or we have seen a lot of challenges, even if we have changes, for instance, at the federal level, that does not necessarily trickle down to all the states, and it doesn't trickle down to the counties either. So it's a monumentous but very necessary effort ahead of us.
And I'll ask folks to, pay attention to what's in the chat box as well. I see a comment from AUPHA about the community health worker initiative that they have to, again, diversify the workforce, and other comments as well. To close this out, what I want to offer to both you, John and Stephanie, is that we've done a lot of work, Council on Linkages, with regard to academic health department partnerships. We have sample MOUs, we have webinars, guidance documents, other tools and resources. And John, please, for your project officers, we're happy to have discussions with them individually or collectively and talk through some of this. Same thing, Stephanie, for the AmeriCorps grantees, happy to do that as well. Because ultimately, at the end of the day, as part of building the capacity for long-term sustainability for workforce development, the pipeline, re-education, et cetera, I think these academic partnerships can be really important for all of that. So, John, thank you so much. Stephanie, thank you so much. Very enlightening. And we look forward to inviting you back again for updating us and continuing the discussion.
Yeah, thanks again for having us, and good to talk with y'all. Take care.
Y'all have a wonderful day.
Thank you. And Bill, back to you.
Well, thank you very much, Ron, and thank you again to John and Stephanie. Very interesting period during our meeting, and we will look forward to hearing from you in the future. Now I'd like to call on Grace to see if she might have the results of the election, and then to give her an opportunity to provide updates on AHDs and the competencies. Grace?
Yes, thank you, Bill. So before I begin with the next part of our agenda, I have the results of our membership votes for both CSTE and FAB. Membership for the Council of State and Territorial Epidemiologists has been approved by the Council, and membership for the Public Health Accreditation Board has also been approved by the Council. So congratulations to both organizations. We are excited for your membership and continued engagement with the Council. So now I'm going to jump in whenever our slides are ready. Okay, awesome. Perfect. So it's great to see you all this afternoon. As Bill said, my name is Grace Davis. I'm a project assistant with the Public Health Foundation, and today I am just going to provide some updates on our academic health department learning community and the activities that we have been engaged in this year. Next slide. So the AHD learning community is a national community that brings together and supports practitioners, educators, researchers, and others to explore AHD partnerships, which are formal partnerships between health departments and academic institutions, as we've been talking about today. The community is designed for members to share their experiences and engage in collaborative learning together to enhance these partnerships. So the community is open to anyone who would like to participate and currently has more than 1,600 members from health departments, academic institutions, and other organizations all across the country. The learning community offers resources and activities to these members and others in the public health community to help support AHD partnerships. This includes providing a venue for sharing experiences and stories of AHD partnerships, webinars featuring examples and stories as well,
examples of agreements that organizations have used to formalize their partnerships. We also have a listserv to enable communication among community members, and we provide technical assistance. So as we've done for many years, we continue to track metrics related to engagement with the AHD learning community and its resources. So the learning community and its resources and tools have so far been accessed over 2,800 times in 2023. And this brings online usage of the learning community to more than 83,000 visits since its launch in 2011. We also continue to provide distance-based technical assistance, as I mentioned, related to AHD partnerships. So far this year, council staff have responded to 18 requests, serving 14 different organizations in 13 states as well as DC. Our presence at conferences has also continued, and we participated in a session at the 2023 Public Health Improvement Training Conference, or FIT, just this month to share information about AHD partnerships. So this session that we hosted was entitled Strengthening Linkages Between Academia and Public Health Practice. And this featured first an overview of AHD partnerships, and then explored how strong linkages between academic institutions and public health agencies contribute to overall public health capacity, as well as the delivery of the foundational public health services. We also had a very engaging conversation surrounding recruitment and retention. In addition, we are currently planning the next webinar in our AHD webinar series, which we expect to occur in late September or early October. As soon as we have additional details about that, they will be added to the council website. We will share them with the AHD learning community, and we will also share them through the Council on Linkages update. So before I move on, does anyone have any questions about the AHD learning community or our activities this year? Wonderful. And as always, more information about the learning community is available through the AHD learning community section of the council website, or by contacting Mayella or myself. So now I'm going to jump in to some updates about another council initiative, the core competencies for public health professionals, or as we like to call them, the core competencies. So the core competencies are a set of competencies designed to reflect foundational or cross-cutting knowledge and skills for all public health professionals, whether engaged in practice, education, research, any sector you may be involved in. And the core competencies have been around for more than 20 years now, since 2001, and they've gone through several iterations, the current version being adopted by the council in October of 2021. The competencies are used in workforce development activities across the country. Next slide, please. So the most current data available show that approximately 80% of state health departments, 60% of tribal health organizations, 45% of local health departments, 25% of territorial, and 90% of academic programs with a public health focus use the core competencies. This data also shows that the core competencies are being used in a variety of ways, including to guide the development of job descriptions and performance objectives, competency or training needs assessments, education and training, workforce development plans, other competency sets, as well as other tools and resources to support professional development for public health professionals. Next slide. The core competencies also appear in major national initiatives, such as Healthy People and accreditation. So Healthy People 2030 includes objectives in the public health infrastructure topic area related to increasing the proportion of state, local, tribal, and territorial public health agencies that use core competencies in continuing education for their personnel. In terms of accreditation, the Public Health Accreditation Board, as we have been talking about a little bit in its accreditation standards for health departments, incorporated the core competencies into Domain 8 of their standards and measures for accreditation, specifically Standard 8.2, which addresses workforce development and requires the creation of a workforce development plan that includes an assessment of current staff capabilities against an accepted set of core competencies. So the core competencies are given as an example of a nationally recognized model that may be used for that assessment. The workforce development plan should also include findings from an equity assessment that considers staff competence in the areas of cultural humility, diversity, or inclusion. And this equity assessment could also be one component of the broader core competencies assessment. For schools and programs of public health, the Council on Education for Public Health has used the core competencies in developing foundational competencies for its accreditation criteria as well. Aside from accreditation, the core competencies are also integrated into the Train Learning Network, which is the largest learning network designed specifically for public health professionals. And this is so that learners can locate courses that will build desired knowledge and skills based on the competencies. And finally, as far as national initiatives go, the core competencies have long been designed to reflect the knowledge and skills needed to deliver the 10 essential public health services. So they are very much related. Looking a little bit at the specifics of usage, so far in 2023, the core competencies have been accessed over 38,000 times online, with over 35,000 visits to their resources and tools in addition. We also have been tracking access to the core competencies specifically since the 2021 version was released, which is now at over 76,000 visits to that web page. Next slide. As with the academic health department learning community, council staff regularly respond to requests for assistance related to the core competencies and development of the professional development that's related to those competencies. So far in 2023, we've responded to 14 requests, serving 9 different organizations in 8 states as well as Canada. So as mentioned, the 2021 core competencies were adopted in October of 2021, and they have been available through the council website since November of the same year. Since that time, we've been engaged in a variety of dissemination activities to try to ensure the public health community is aware of and has access to this latest version for their workforce development efforts. We have also continued to work on updating and developing resources and tools that support individuals and organizations in using those core competencies. So we have shared this previously, but these updates began with the competency assessments, as this is the set of tools we had gotten the most requests for, and versions of these assessment tools that reflect the 2021 version of the competencies are available on the council website. The 2021 core competencies have also been made available on the Train Learning Network as a search filter. So this allows course providers to identify which of the competencies their trainings help build, but also helps learners to locate trainings that may address specific competencies that they're working on. A little bit more recently, we have updated a competency prioritization tool that supports organizations in identifying the most important core competencies for different public health jobs. And this helps them in determining where to focus their competency development efforts. So I'm actually going to turn it over to Ron for just a minute to talk a little bit about what we're hearing from the field about the use of this prioritization tool.
Thank you so much, Grace. And it, with the increased attention to public health workforce development, with health departments moving from their COVID-19 response activities to looking at ways to rebuild and revitalize their workforce, more and more health departments have been approaching us and asking about how to use the core competencies. And what we're finding is the prioritization process is making it easier for them to use the competencies, A, and B, helping the workers within the organization better understand how the competencies relate to them. One example that we had recently was the Kentucky Department of Health, where they went through a process of categorizing all of their staff into different job categories and then convening people within each of those job categories for about 2 hours and the questions being asked about priorities, and there's a prioritization process in the tool that uses some QI processes there. And at the end of that whole exercise, you end up with about 8 to 10 priority competencies per different category. Then rather than asking about all 56 competencies and how they relate to individuals within the health department, you can ask the question, you can assess based on those priority competencies. It's less burdensome for staff, and because the staff have identified these as priority, they better understand the relationship. And then when you do survey, it has greater relevance. So what we've been hearing from several health departments is a preference to prioritize first before assessing. But I don't want to say you can't do it the other way. A lot of health departments still do the assessing on all 56 competencies, and then they go through a prioritization process. So just thought I would give you a little bit of a taste of what we are hearing in terms of practical use in the field. And Grace, back to you.
Thank you, Ron. And we're excited to continue to hear how the prioritization tool is being used and helpful to those using the core competencies. We have also recently finished updating domain definitions to describe the contents of each of the 2021 core competencies domains. So you can see there's a screenshot of that here on this slide. You can see 4 of the domain names and the definitions that correspond with those domains. So this tool is available on our website, and we're excited to kind of just delineate what's within each domain of the core competencies. And then next slide, please. We also are excited that our core competencies general tools page has also been updated. There's a new format that highlights resources for the 2021 version of the competencies, and all tools we've talked about here today can be found on this website. And as we continue to release and update tools, they will also be found here. And as we continue to work to update and develop resources and tools, we will also continue to send updates through the Council on Linkages update, and resources and tools will be posted on the Council website as they are completed. Does anyone have any questions or comments about the core competencies? Well, wonderful. Please feel free to reach out to Mayella or myself again at any time. As always, more information will be available through the Council website as updates are made. Thank you all.
And thank you, Grace. Thank you very much. Now we come to the point in our agenda where we're going to ask council members particularly, but also our guests, if you are interested, to take a look at our council strategic directions proposed revisions. Public Health Foundation staff has prepared or proposed rather some revisions to the strategic directions to reflect current activities and priorities, essentially update the council strategic directions. I've reviewed them and agree that they should be presented to the Council on Linkages for consideration. And Grace, if we could move now to we could share the slide with the strategic directions, please. Or that would be Mayella, whoever is doing that today. Thank you. We not planning to spend a whole lot of time here, but a few things just to set the stage. You know, a long time ago, shortly after the council was formed, we agreed on a mission statement, which you can see in front of you. And then we set out to describe objectives, strategies, and tactics that would be appropriate for the council to work on if both the need for the work and the resources were available to do it. So I want you to understand that the council is not involved in pursuing every strategy or tactic in this document, really far from it. Instead, we looked at what the council is, what its mission is, and then decided to see if we could figure out exactly what the council might do should the resources become available. And it's been up to the council, of course, to decide its priorities and then also on our funders to decide whether they agreed with what we intended or hoped to do. So we came up with 4 objective areas. If you could move it down a little bit. Yeah, there they are. And so we've been working within those 4 major objectives. As you can see, the strategies and tactics flow beneath each objective. And if you remember on our agenda for council meetings, you'll note that there are indications of which objective, strategy, and tactic the particular council item is related to. And that's been our effort to be sure that the council is focused on what it said its mission is. So understand that we are looking now at what it is that is appropriate through the window of the council's perspectives on what it can do to contribute to improving public health in the community in the US. So if we move down to the bottom of the page here, there are these changes suggested here are just really words to try to clarify what was implied here. There's no substantive change in what the intent of the strategy B is. So highlight, and it doesn't show up here so much. The way that reads now is document and disseminate progress in academic practice collaboration and the impact of that collaboration in public health. So it's a little hard to read, and you see the highlight is crossed out. Can
Bill,
people see that?
Bill, the version that I'm seeing has the track changes in it.
Yes, it's just hard to see what's crossed out and what's underlined. But the underlining is the new stuff, right?
Correct.
Yeah. So what I'm hoping we'll do is I'll go through and point out the changes that have been made. And then we'll be open to any comments anyone wants to make, council members or others who are on the call with us. But we're not looking for a decision today. Instead, what we'd like to do is take the comments we received today, if any, and then ask you to take this document and for the council members to share it with the leadership of their various organizations, to get responses from that, and then to get things back to us within the next month. So by near the end of July, we'd like to hear from everybody who has something they wish to contribute. And then what we will do, we'll work with the staff to take the comments and suggestions and rework the document to the degree necessary and present you then with a hopefully a clean copy of our suggestions, and then we can vote on it at that point. Okay. So this is today, it's to introduce this to you. It's for information, to help you understand what we're suggesting, and to take any comments you have today, but not to make a decision today. Okay, if you would move down the page then. There's some changes here. And you can see there are a lot of words crossed out, and essentially what we did in D here was say, we're going to coordinate with other national initiatives, such as the Public Health Infrastructure Grant Program. In other words, most attention is now focused on the PHIG. So we thought it best to refer to it rather than this laundry list of things that we would be paying attention to along the way. We know most of the energy and attention is going to be focused on the Public Health Infrastructure Grant Program. So our suggestion is fairly simple and straightforward there. We go down now to strategy 2. Here, we subtracted a tactic. As you can see, the tactic identify population health competencies aligned with the core competence public health professionals that are designed for non-clinical settings. Replacing that with a tactic that says review the competencies for public health professionals for potential modifications, because they have now been developed and we're at the point where they exist. So our job now is to look at them, make sure their usefulness, and make sure they crosswalk reasonably well, as others have pointed out, with all of the other elements that are associated now in our modern public health. So that's the change suggested there. Okay, then let's see. Now I think come up just a little bit, the page a little further. I'm looking at strategy 2. Yes. Okay, we just did that. I'm sorry. So let's go down to the bottom of the page. And here in tactic F under strategy 1, we just changed advance opportunities to identify and advance. Thought we better make sure that we could find them first, and then when we find them and agree on them, then we would consider what we could do to advance them. Okay, down further. All right. So here, contribute to efforts to use and improve quality standards for public health training because they have been developed, and to then withdraw or eliminate previous tactic C, because as we looked at that, we weren't sure what it really meant. It's kind of wordy, and as we looked at it, it didn't really make a whole lot of sense to us. So we thought we'd change it to something else. And it's not, let's see. It's not necessary to focus here because of a variety of, I can't read my notes here, of
Yeah, Bill, I think it was.
continuing education opportunities for public health, right? Yeah.
Right. We were also talking about the certification in public health and things
Yeah.
of that nature where there are CE requirements already in place.
Mm-hmm. Yeah. So it simplifies that. And I think that's the last change we've suggested. Is it not one more? Oh, yes. Okay. And here in objective C, we're looking at adding an element here, a tactic to identify additional data needed to support development and implementation of a comprehensive plan for the public health force. We're sort of looking at the flow here. If you say we're using existing data to better understand the composition and competencies of the public health workforce, but we might also find the need to find additional data to do that. So we just tried to complete that and make it appropriate. And D we removed because we're really now not, we don't find it necessary to determine the contributions of credentialing. It's not, we didn't think something that the Council on Linkages really needed to do at this point. Okay, and then here, identify skills needed for health professionals to assume the responsibilities of the community health strategist. That really came from Public Health 3.0 language, but we thought it more appropriate now to suggest that we identify skills needed for public health professionals to deliver the foundational public health services. Just thought that language would be clearer, more direct. Okay. And that's the end of the changes. I'm sorry, I messed that up just a little bit, but I hope that gives you at least some idea of what we're trying to do to keep these items relevant. And so let me ask now if there are any comments or questions or suggestions at this point. Okay, so hearing none, then we'll come back.
Bill, Gary took himself off mute, and then
Oh,
also I see Terry's.
there he is. Mhm.
Thank you. My comment, thank you, Ron, as well. My comment is that I think that this further clarifies and updates the material very nicely. And I will take it back to our organizational leadership. But my review, and I went through it, Bill, maybe just as carefully as you did, and I really felt it was updating and clarifying at the same time. And that would be the individual feedback that I'd like to provide. Thank you.
All right, thank you very much, Gary. Terry?
Okay, thank you. Looking specifically at objective C, strategy 2B. I think that's the last one that you referenced there.
Yeah.
I guess maybe a question and comment. Certainly removing, we've replaced the community chief health strategist with the foundational public health services, and I do understand that. A couple of comments. One in terms of identifying skills for the chief health strategist. Actually, NACCHO has done that in their Workforce and Leadership Development Committee, developing a set of competencies, both knowledge and activities for the chief, we call it a community health strategist. We dropped the chief part. So that has been done. So I think, so identify skills, well, our organization has done that. So, so from that perspective, it can be, eliminated and shift now towards identifying skills needed for the foundational public health services. I believe through FAB, there is a self-assessment tool around those services. So I don't know if there's actually a set of competencies, but so I think that is starting to form, which would meet this goal of identifying skills. But the one piece that I may be missing in this is that, first of all, I was looking at why public health foundational services. And I think the research is there in terms of this is where a 21st century health department needs to go. And by identifying competencies for foundational public health services, you've got the what, you set the bar, so you've got the bar set there. But the step that may be missing, and you deal with this in strategy 3, where you talk about the actual implementation of bringing those foundational public health services in my case, into a local health department. And that's the how. And so the how is missing there. So I think identifying the facilitators and barriers would be important in this around the implementation and plans to implement, just as you've done in strategy 3, where you've supported departments implementing the core competencies for public health professionals. So that may be an area that you may want to consider as you're using, I believe what you're doing right now is trying to set the bar for saying you're proficient at the foundational public health services. I rambled a little bit there. I hope you got the message in there, and maybe NACCHO would can follow up with perhaps a more bigger response to that. So thanks, Ron.
Bill, do you mind if I chime in for a moment?
No, please do.
So a couple of comments. Thank you, Terry, for bringing that up. Something I should mention in relationship to this, since the time that we suggested this revision, we began working on a crosswalk of the foundational public health services with the core competencies. And what we saw as we were developing that is that a crosswalk of 50 by 50 and X's all over the place, that basically all of the core competencies relate to the different parts of foundational public health services. And in fact, many of the capabilities are similar names as domains. So what we've concluded really is that the core competencies in their entirety really serves as the foundation set of skills and competencies for delivering foundational public health services. Moving to your question, then it becomes how do health departments actually use that? And so I think that's something we should look at and explore. And, you know, Terry, be happy to have additional discussions with NACCHO, you know, you and others about that. What are the barriers? What are the facilitators? I think that is very, very important to all of this.
Yeah.
Hope I didn't confuse matters, but
No, well said. No, you helped bring confusion where I was confusing it. So you brought clarity rather to an area that I was providing some confusion.
And Bill, sorry, one other thing I failed to mention is that, Terry, your comment about what NACCHO has already done is great, because this Council on Linkages set of strategic directions isn't for all staff to do, it's the council. And so there may be individual council organizations who adopt a particular strategy and say that's something we're moving forward, and then being able to report back to the council and get some feedback and let us know where things stand. I think that's really what this is meant to be. It's the entire 24 organizations of the Council on Linkages. What can we do together, as well as what we can do individually, and then leveraging the together.
Well said. Other comments or suggestions? Well, in the absence of more comments now, I don't see any hands up at this point. No. Then please do what Gary said, promised us he would do. Take this, share it with the leadership of your organization. Let us know what you think. Terry, I think we can expect something from NACCHO, which would be very helpful. And we'll look forward to getting any input that any of you can provide. We will do our best to put it together into a reasonable document, and we'll share it with you again. Maybe hold a vote online later before our next meeting. We'll see how it goes, but that would be our intent, our goal. But please do it in the next 3 to 4 weeks. Get it back to us by this time next month so that we can proceed to get it done by during the summer. All right. Okay. Now, if we can, let's like to move to Sarah Auer, who's the program analyst at the Council of State and Territorial Epidemiologists. We'd like to hear from Sarah about the newly revised applied epidemiology competencies. Oh, Sarah, please, the floor is yours.
Awesome. Thank you so much for having me. Really excited to provide an update on the applied epi competencies, which we recently updated. My name is Sarah Auer. I am an analyst at CSTE and have had the pleasure of being the lead for this project. Next slide, please. So first, I just want to kick off with what are the applied epi competencies. Next slide. So in 2008, CSTE and CDC embarked to develop the competencies with the aim to improve the practice of epidemiology within the public health system. We did define the competencies for 4 tiers of epidemiologists, and this was really based on their level of responsibility. So we had entry level, mid-level, supervisory, and senior scientists. And these were actually developed within the framework and in alignment of the core competencies for public health professionals. And we saw the 3 target audiences for the competencies as practitioners, employers, and educators. Next slide. And here are a couple of the reasons why we find the competencies to be so important. So they help to define the role and skills of epidemiologists in the field. We find them really integral for creating job descriptions and career ladders, and they outline the skills necessary for the training of future epidemiologists. They also ensure that EPIs are in alignment with current methods and technology, and it helps to standardize the function of the epidemiologists across health departments. Next slide. So now I just want to touch on the revision process that we went through over the last 1.5 years. Next slide. So we really set out to assess and revise the 2008 competencies because we wanted them to be in alignment with the revised core competencies for public health, and we wanted to put a particular emphasis on things like data science, communication science, pandemic preparedness, and diversity, equity, and inclusion. Next slide. So we took kind of a multi-pronged approach. We did conduct a literature review, which really helped us to understand how the 2008 version was used and also helped us define the role of an epidemiologist now. We also created an expert panel of 20 members, which represented governmental, academic, private, and nonprofit public health members. And they were really integral to review feedback and help make decisions on revisions. And kind of taking note from how the core competencies were done, we also held a number of town halls, as well as some focus groups and interviews. But this really helped us to gather insight from the field on what needed to be revised about the competencies. And then we also created an evaluation to measure achievement of the competencies and create tools to both self-assess and have a supervisor assess competence. Next slide. So we did host 6 town halls from February to March of 2022 to gather feedback on the competencies. We had 223 unique participants representing 43 states. And we did kind of track where folks were joining us from. And the majority of participants were from state health departments. Next slide. So now I just want to focus on some of the major updates that we've made to the 2023 version. Next slide. So a big thing that we did change was the tier structure. So we did get feedback that the tiers are useful, but many departments started hiring at a tier 2, which is that mid-level, and upper tiers needed more flexibility because some senior level epidemiologists do become managers and some do not go down that path. So in our updates, we made the tiers more skills-based and we created flexible paths for managerial and non-managerial roles. And as you can see here, tier 1 is foundational. So we think about academically focused, those graduating a program of public health. Tier 2 is intermediate. So somebody who's really focused on managing epi programs. Tier 3 is practice, which really focuses on managing resources, money, and epidemiologists. And Tier 4, which is advanced, which is a leadership role, a visionary, a senior level epidemiologist. We also did remove some of the requirements that we had around education for each of the tiers to kind of ensure that we were taking a holistic perspective on experience and the different things that people brought to each of these tiers. Next slide. We also did update our domains. So we did align all of our domain names with the core competencies for public health. We also decided to take out, we previously had domain 5 as cultural competency, and we decided to actually infuse health equity concepts throughout the other domains instead of having an individual domain. So we went from 8 domains to 7 with the thought that health equity would be infused throughout the other domains. We've also kind of separated out our domains. So domain 1 through 4 are technical core domains. So those are domains that are really relevant to be the position of an epidemiologist. Whereas domains 5, 6, and 7 are our leadership and management domains. These are still critically vital to being an epi in a health department, but they could also apply to other public health professionals. Next slide, please. So this is kind of the figure that we've developed to showcase these domain updates and the competencies themselves. So this idea, once again, that even though we don't have health equity listed as its own domain, it's infused throughout our other domains. We also created these wonderful icons as a way, as you're moving through our tool, to kind of keep track of which domain you're in. Next slide. We also changed a great deal the format of our competencies. So this is an example from 2008. And this, we found that we had a lot of similar skills across tiers, and it resulted in a great deal of repetition. So we've actually updated them so that, if you go to the next slide, please. The 2023 format actually focuses on, if you have one competency, how each of those 4 tiers contribute to achieving that. So the thought is that as you move from foundational to intermediate, that you know how to do both the foundational subcompetency and the intermediate subcompetency. This helped us abbreviate the competency list quite a bit, but also focus on each of these areas doing something different as opposed to having a great deal of repetition across them. And it really focused on that skills building and advancement. We also updated it so that we have a competency and a subcompetency, as opposed to previously having a competency, subcompetency, and a sub-subcompetency. Next slide, please. So I also just wanted to highlight some things that were really prioritized in the content changes. So one, we really wanted to make sure health equity was really prioritized. That we also talked about data visualization, acknowledging how much has changed over the last years. We also really wanted to highlight accessibility, as well as the topic of public health policy and law. We also wanted to acknowledge that EPIs often interact in cross-sector collaboration and include things like cultural humility, social determinants of health, the class standards, as well as change management and really supporting and working with communities. Next slide, please. And as you're all very familiar with, we also wanted to be sure we were in alignment with the core competencies. So like I mentioned previously, we did update the domain names to be in alignment, acknowledging that a lot of folks use both in tandem, so wanted to make that easy. We also took note of how well you coded the competencies. So we did that similarly for easy mapping. And we also wanted to make sure that we added things like structural inequities throughout all domains. We did explicitly add the 10 essential public health services, and instead of avoiding exhaustive lists, we utilized examples, which we thought was a great demonstration in the core competencies, so we carried those into the applied EPI competencies. Next slide, please. So just kind of want to touch on some of the applications in the field that we found with the competencies. So we found, especially from feedback from our communities, that they're a great resource for creating job descriptions, using them to determine training needs and create training plans. They're also helpful for career portfolios, as well as fellowship programs. We do use them for our Applied EPI Fellowship, and they are used in the EIS program with CDC. They're also integral for training graduate students and junior epidemiologists, defining epidemiology classifications in health departments, utilizing them for performance evaluation for promotion, as well as salary survey and market analysis and self-assessment. Next slide, please. So just kind of want to touch on how they'll be featured at our annual conference next week. So we are excited to host a workshop on Sunday to kind of help launch the competencies. We will be featuring jurisdictional presentations from folks who have used the 2008 version. And then we also have an interactive component with templates for utilizing the competencies for creating things like career ladders, position descriptions, and training plans. We're also excited to host a roundtable, which will give kind of similarly an update and talk about the applications of the competencies. But we also wanted to provide an opportunity for discussion to discuss strategies for updating competency-based materials in the STLT setting. Next slide, please. So thinking about next steps, where are we headed? We're very excited to move forward with creating an applied epidemiology competencies toolkit. So we really want to create this toolkit to support use and implementation of the revised competencies. So this will include things like those templates for creating job descriptions, career portfolios, and training plans. We are excited to also be creating training on CST Learn, which is our LMS platform, for implementing the competencies in the STLT environment. We will also be publishing those evaluation tools that we've created for self-assessment and supervisor assessment, and creating things like job interview questions and skills-based assessment activities to support the selection and hiring process. So looking forward to kind of getting that started as we roll into the summer. Next slide, please. So that kind of concludes my updates. Happy to take any questions, but if you have additional questions about the revised competencies, please always feel free to reach out to wfresources@cst.org, and we will be formally launching them in July, so keep an eye out for our webpage updates. Thank you so much again for having me.
Thank you so much, Sarah. Does anyone have any questions for Sarah? Yes, Gary?
Thank you. Thank you, Bill. And Sarah, thank you for that overview. It was very well presented, and obviously you were at the core of a lot of these activities. First of all, just a quick comment. I applaud the overall process that was used to include the panel and the town hall approaches, just as a couple of what I would consider to be major examples that enabled you to accomplish this overall process. I was interested, and I wanted to give you a chance to comment on this. an area that might be an enhanced area of prioritization that we don't usually see as public health epidemiologists. But I was delighted to see in your overview, and that is working with communities. Is that, to your experience with the process, something that you truly, and the panel and others truly wanted to prioritize and enhance? It appears that way.
Yeah, absolutely. That was definitely a topic we heard from our town halls and from our expert panel. And it really came up in the topic of, if we want to be accessible, if we want to be equitable, that really involves working with community, not studying community, but really having folks be integral in how we create epidemiology studies and how we operate in health departments. So as you look at the revised version, I think you'll see a lot of language that talks about that collaboration and that like bilateral relationship, as opposed to the health department coming into a community, working in that community, and then leaving again. So that is definitely something we tried to emphasize.
Outstanding. Thank you so much.
Yes, thank you.
Mhm. Thank you both. Are there any other questions for Sarah? Okay, I see none. So that brings us close to the end of our agenda. Let me ask if there is any other business any council member wishes to bring up at this point. Very good. So that will bring us to the end of the meeting then. Just a reminder, we have one last council meeting scheduled for 2023, which is now scheduled for Tuesday, September 26, starting at 2 p.m. And as always, if you have questions about that or anything else related to the council, feel free to check back with us, particularly with Mayella. So feel free to, there's her email address for you. So feel free to check with her, just as you felt free before to check with Kathleen. All right. And with that then, thank you all for being very efficient and very productive. We're just within 2 or 3 minutes of our planned ending time. That's always happy news. So with all of that, let me declare the meeting closed, and we'll look forward to seeing you all next time. Thank you for your participation again today.